So let's look at today's agenda. So we're going to start, Dr. Lucy is going to start us off with a bit of an overview around some of the most common mental health conditions that you might come across in the workplace. So that should be a really, really interesting session. And then Heather's going to then take over and look at how then that links into the workplace. So what impact that might have, the implications from an employment perspective, and how that is relevant to when you're managing people. We'll then look at what preventative measures can be put in place around, exasperating mental health perhaps in the workplace, looking at spotting the signs of an issue if you are managing people, and also how we can signpost formal support. We'll then look at a couple of case studies. Then we will finish with what can go wrong. Yeah, it sounds a bit doom and gloom, but if we don't get it right, what the risks are, I suppose, is a better way of putting it. And then we'll finish with a Q&A. Just before we do jump in, obviously mental health is very, very topical, and it's certainly something which in practice we've seen a significant rise in the last, I'd probably say 4 to 5 years, in terms of how often it's becoming an issue or a problem when it comes to managing people. We've also seen a rise on top of that coming out of lockdown. So obviously COVID's had a huge impact on people's mental health, and obviously that then does unfortunately transcend as well into work. So it is one which is at the forefront of our minds as your advisors, but also I think from a management perspective. You unfortunately now you can't ignore it, and you've got to be aware of it. And I think that's the purpose of today's session, really, is to just raise awareness. And it's certainly not about us all coming away from the session thinking that we're going to be counsellors or experts or be able to solve people's problems, because unfortunately it's not that simple, is it? It's more around awareness, and it's about being able to identify if you have got someone in your team that is suffering or has a condition that does impact on their performance, how you can support that person, or how you can make adjustments, or how you can manage that person safely without causing the business risks. So that's just a sort of introduction really into the purpose of the session today. So I think I will now hand over to Dr. Lucy, if that's okay with you, Lucy, just so that you can take us through these conditions that we see quite often.
Yeah, good morning everyone. I'm Lucy, and I'm a clinical psychologist, and I've been working in mental health for just over 10 years now, and the bulk of my work has been with adults experiencing mental health problems. So like Stacey said today, or initially, I'm just going to go through some of the more common difficulties that you may come across as employers, and you may come across with your employees. And just to say before we start, just what I wanted to mention is that sometimes in services in practice, we might use different terms or labels to describe certain diagnoses. So you might see, for example, depression being described as depression on a sick note, for example, but you may also see more descriptive terms like low mood. And I think we tend to use them terms interchangeably to describe the same sorts of experiences. So different professionals will use different terms. And that's because we've become much more aware of the use of language over the past 10 or 20 years. And what we can find is that diagnostic labels can be quite stigmatizing sometimes, and people prefer more descriptive labels. So professionals will sometimes prefer using diagnostic terms, and sometimes will prefer using more descriptions. But generally, we're talking about the same things, I think, from my experience anyway. So I'm starting off with I suppose the most common difficulties in terms of what you might come across, which is depression and anxiety. So depression or low mood is relatively common. So if you had a room full of 100 people, at least 3 of those people would be meeting the diagnostic criteria for depression. And that is mainly characterised by persistent feelings of extreme low mood, and this is alongside feelings of worthlessness and helplessness. And people who are experiencing this will often also notice that these things are having a really significant impact on their quality of life and their ability to do their usual activities. So it'll impact on their social life, on their work life, and it'll make doing them things really, really difficult. People will often report difficulty sleeping or oversleeping. They may have problems with appetite, difficulties concentrating, and all these things make it really difficult to kind of maintain what we would our usual activities. And then anxiety, that's probably the most common difficulty that you're likely to come across. And so that's much more common, I suppose. That's 6 in 100 people. And anxiety is used, or the word is used to describe someone who is worrying excessively about something. So they'll have this apprehensive expectation that something bad is going to happen, and they will spend a lot of time ruminating, thinking, worrying about different things. What we find in services is that with anxiety, people can fall into different categories, and we tend to categorise people. So some people might worry about specific situations, so they might worry about social situations, which would be social anxiety, or you might have worries related to certain themes, such as health anxiety, or you will find some people who just use the process of worrying to manage everyday issues and problems. And that's when people have a more generalised anxiety disorder. With anxiety, what you will find alongside the worrying is that this will start to have a significant impact on their day-to-day activities. So people will be finding it hard to concentrate, they may feel really tense, and what tends to happen is your body goes into this fight or flight response, and you're trying to maintain that for quite a lot of the time, which is really, really hard. So it can be quite exhausting as well. You can be restless and irritable, and we see that quite a lot too. So yeah, and then I've also put psychosis down there. So that's probably that is less common, but it's still something that you might come across. I think, or what I know is that research and support for this group of people has massively increased over the last 20 to 30 years, and the help on offer is now, really, really good. So psychosis is most commonly associated with the diagnosis of schizophrenia, but the term psychosis is used to describe a set of symptoms or experiences, and this usually falls into 2 categories. So people will often report having quite strong, unusual beliefs about certain things, and that might relate to feeling paranoid or feeling like they're being followed, but it could also relate to it could also be beliefs around religion or a sense of grandiosity. We see that sometimes, but what we do see is that the beliefs tend to fall into certain themes that overlap across everybody. And then alongside the strong unusual beliefs, you will also sometimes have hallucinations, so hearing things that other people don't hear, and seeing things that other people can't see. And what we know with psychosis as well, like other mental health difficulties, is it's often a build-up to these problems. So people won't just wake up one morning with these experiences. There's often a build-up that can be that is often related to something going on in that person's life at the time, and it will get to the point where that person's in crisis and they might start acting quite erratically, and it can be quite frightening to people. around, and but often it's because that person is quite frightened that they might be acting that way. So and like I said, for people, for this group in particular, if you intervene early, what we know is if you intervene early and if people get help early enough, and help is usually medication or therapy, that people do get better, and it doesn't necessarily mean they'll have another episode. You know, they can get better and they might never have another episode again. So, and then the next one that I put down there is mood swings, which I probably should have just put alongside slash, I suppose, what bipolar disorder, which is probably what is most commonly known as. And bipolar disorder is characterised by extreme mood swings. So that will typically range from extreme highs, which we call mania, to extreme lows, which would meet the criteria for depression. And again, these episodes tend to be triggered by certain things going on in that person's life. The episodes of mania are often characterised by somebody feeling really full of energy. They might have a sense of self-importance and be really elated, and may start acting a little bit out of character. They may, it's also associated with taking, I suppose, with quite risky behaviours. So they might start spending money they don't have, or putting themselves at risk. And when I've spoken to people about what it's like to be in these states, people have often said it's like being on a drug. So it can actually feel quite good to the person because they're really productive, everything's going great. But for the people around them, it's quite worrying, because often you're not sleeping as much, you're not looking after yourself. And then that period of high mood is then often followed by a period of low mood. And what we tend to see is that the period of low mood is often, or can be, linked to people's worries or concerns about what they've been doing whilst they've been high. So what have I said to people? What do other people think of me? But as well, that they will be meeting criteria for depression. Them states or them periods of high and low moods can last from anywhere between weeks or months. And then in between those episodes, people will often return to a normal, I suppose what we would consider to be normal mood, whatever that looks like, and will be able to function quite normally. Again, the support and treatment on offer for this group of people is getting better. So with help, often people can manage their moods and may be able to notice signs that their mood might be increasing and be able to do something about it before it gets really extreme. And then I've also put stress down there because I'm sure that you're likely to come across that as employers. It's not necessarily a diagnostic category, but I suppose it describes a difficulty that someone might present with. And I guess it's important to say that small amounts of stress are actually quite good for us. So and we actually perform quite well when we're under stress for short periods of time. So, for example, if we have an important meeting or we have an interview coming up, our bodies will often go into a state of stress where you might be overthinking or not be able to think about anything else. You might be struggling to sleep, or you might lose your appetite, and that's because your body's kind of going into this fight or flight mode and getting prepared to kind of go into this particular event. And it often means that we're quite focused and we will perform quite highly, and then after the event, then stress levels will come down and will return to kind of normal functioning. But for people that are experiencing chronic stress, that's often because the stressor isn't something that kind of comes and goes quickly, and people are experiencing these like long-term physical effects of stress, which initially may improve their functioning, but over time it leads to a decline in functioning because it's exhausting being stressed. Again, we're not meant to be in that state for long periods of time. And just to go on to the next slide, Stace. So what we've found is that absence due to work-related stress has remained pretty stable over the last 20 years. But since 2019, there's been a slight increase, well, not a slight, quite a significant increase. And when I was reading a little bit about this, and there was some thoughts that it might be related to COVID, which is likely to be in some way, but actually there seems to be more going on than that, and it isn't just attributable to the pandemic. And that's what we find, I suppose, with mental health, with distress, is that nothing's ever simple, and people are complex and distress is complex. So if you just go back for this. And then the next couple of things are related to intrusive thoughts and obsessive compulsive behaviours, or what you may know it as obsessive compulsive disorder. But you can have intrusive thoughts without the obsessive compulsive component, I suppose. And intrusive thoughts, we think of intrusive thoughts as unwanted and distressing thoughts. And these are all thoughts that we will all have. They're quite normal. So, for example, I might have intrusive thoughts of sometimes when I've got a little boy, and if I'm holding him, I will have a thought of dropping him down the stairs, and that's unwanted, and it will kind of come into my mind, and I'm like, where did that come from? And it's completely normal for us to have them thoughts. But for people who have obsessive compulsive behaviours, what tends to happen is that they will have these thoughts that are related to some sort of theme, and they will feel they will feel compelled to act on them. And if they don't act on them, then they will feel really uncomfortable about it. So often they will engage in behaviours which will reduce their anxiety in the moment, but that cycle is then very likely to return when you have another intrusive thought. So OCD, I suppose, in the media, in what people kind of associate it with is people washing hands or cleaning excessively, and that's but it can be linked to lots of different behaviours, I suppose. But what is happening is people are having that thought and feeling compelled to act on it, and then that cycle is repeating itself. People like with the other difficulties that I've described, people with OCD can function really well and manage really well with these difficulties. So and what we tend to see is that an increase in stress, a change in somebody's personal life or professional life can trigger off like an increase in these difficulties, and that covers all mental health problems. And also, just to say as well, what we do find in practice is that people often won't just fit into one diagnosis, that people will present with lots of different difficulties, and they will probably meet criteria for a number of problems as well. And then the final one that I put down there is suicidal thoughts, and this is probably captured most in people who are experiencing extreme low mood, but it is something that possibly that you might come across, and this can range from people having intrusive suicidal thoughts they don't necessarily want to have, to people who are seriously considering taking their own life. And I think I'm going to pass over to Heather now for her section.
Thank you very much for that, Lucy. That was absolutely fascinating. I hope everyone found that useful, just to have that overview really of the different types of conditions and what they actually look like. So that was great. So thank you. Heather, I'll flick through to your slide. Perfect. Is that okay?
Thanks, Stacey. So having that really good knowledge about bit of a better understanding about what some of these conditions might be, I'm now going to focus obviously on my area, which is looking at how we might find these people within employment, or when these problems might be triggered. As Lucy's mentioned, it might be actually something work related that triggers some of these mental health conditions, or it might be another issue in their personal life, or another long-lasting condition that they've had for many years. So the first thing that I wanted to mention is quite often the first an employer might know about a mental health issue is when there is either a disciplinary or grievance issue that has arisen. And that might be because they are able to function quite normally day to day, but when something has arisen in the workplace that has caused them some sort of stress or prompted a reaction, then that's when we might be seeing a mental health issue arise. So this might be when someone becomes aware that you are investigating their conduct, or you're having to speak to them about misconduct on their part. Now, that might prompt some sort of stress reaction or some other mental health condition, and that might become entirely genuine. As Dr. Lucy said, that might be a trigger for somebody. Sometimes I think we see there's a bit of cynicism, and it might be an avoidance tactic to facing up to a misconduct issue, and it might be their way of buying some time, of avoiding being in the workplace and having to address it, or maybe even they think they're going to lose the job, and it's time that they can spend focusing on finding another one, because that's obviously of very much importance to somebody. So they may well fall into genuine or not genuine issues there. And I guess in terms of a grievance issue, I've thought about this from both sides. So it might be that the employee has been the subject of a grievance. So someone has accused them of bullying or some other untoward conduct. And if, again, as we're investigating that grievance, we might see the subject of the employee who's the subject of that grievance raising a mental health issue. That might be to try and explain their behaviour, or it might be that acute sort of reaction to that workplace issue or dispute, or again, it could be an avoidance issue. Similarly, it could be on the flip side that the employee that's raised the grievance has a mental health issue. It might be that they are being bullied at work and they do go off with work-related stress and raise a grievance at the same time, or raise a grievance while they're off with a mental health condition. Or it might be that they're feeling harassed, or that they're not being supported in the workplace because of their condition. So again, that could fall into a number of different scenarios there. I think the other time that's very obvious that we might deal with people with mental health issues in the workplace is when we are managing attendance. So we tend to think about attendance issues as falling into two categories. That might be long-term, which I think typically most employers would probably treat something as long-term once it's over 4 or 6 weeks in length. Or if they're having persistent short-term absences, and that might be all sorts of different patterns. Again, Dr. Lucy talked about how, say, somebody with mood swings or a bipolar disorder, they might be in work and functioning well for periods of time, but then have an episode or a flare-up of their condition and be off, and we might see a repeating pattern there with persistent periods of absence, but each absence being relatively short-term. Now, clearly, both of those can be very disruptive operationally for the employer, and difficult for the employer to manage, and having impact on the team, etc. But obviously, we do need to be aware that I think traditionally, perhaps mental health issues have not necessarily got the same reaction from employers in terms of empathy or sympathy as perhaps some physical conditions. Maybe that people feel is definitely genuine, because, you know, if a doctor's diagnosed you as having had a heart attack, you've had a heart attack, and people see that as a real life-threatening condition, and would probably have a lot of sympathy for somebody who'd been signed off with a heart attack, as compared perhaps to somebody who's been diagnosed with what they may say is, oh, mood swings, and that's something that we all have, or, you know, my partner's got terrible mood swings, and sort of trivialize it somewhat. Now, I must admit, until Dr. Lucy said, I didn't even realise that mood swings could be that descriptive term for bipolar disorder, which I am, you know, do have some familiarity with. So again, perhaps the more descriptive language has been used either due to the patient's choice or the doctor's preference, or what have you, and so it doesn't sound, you know, low mood. Again, people say, well, yeah, I have low moods, don't we all, bad days, etc. But the reality is that if they are getting signed off by a medical professional with a mental health condition, we should be treating that in the same way as physical conditions. And then performance management, again, I guess similar to your discipline and grievance, but I don't think I've come across an employee yet, or a situation where people have welcomed and found it absolutely fine to be performance managed and not found that difficult. Of course, we all want to do well in our job. We all want to be told we're doing a good job. We seek that praise, and we want to succeed and achieve. And I think majority of people feel that way. And if their performance is such that they are needing to be formally performance managed, and that involves a process which could result in their dismissal due to capability, then that can be really, really difficult for people to accept, and people can take that very personally, be very, very defensive, and I'm sure find it very, very stressful. They're probably fearful of losing their job. They may perceive it as bullying type behaviour that may trigger issues for them in terms of their mental health. And look, sometimes it might amount to micromanagement, or if it's not done well or in the right circumstances, then there's reasons sometimes why people feel that way. But hopefully, again, if you're getting support with how to do those HR processes properly, then let's try and keep it positive, and performance management should be in part how we can support that person with achieving the standards that we need, and not just telling them they're not doing a very good job. And we do have to take into account any sort of mitigating or extenuating circumstances, which could include mental health issues if that's impacting on the performance. The last one I just thought I'd touch on is informal welfare discussions. So again, with a lot of employees working from home now, this is more and more important. Are we having regular one-to-ones with our team? Are line managers equipped to sort of check in with their staff in a way that is constructive, and trying to make sure that we're sort of relatively comfortable that our employees are well, and that they are able and have got the tools they need to do their job? And so I think in those discussions, sometimes things can come out regarding mental health difficulties. And that's why obviously we're going to go on to talk about how we might then signpost that, or what we might need to do if someone does tell us informally that they're really struggling with their mental health. Thanks, Stacey.
Oh, thank you, Heather. That was great. Okay, so if we can now look, Dr. Lucy, at some of the signs perhaps that managers can, you know, look out for, be aware of, in terms of their teams, that may suggest that there's something underlying with that, you know, with that particular member of staff.
Yeah, and I think a lot of these that I've listed here fall into like a category of noticing a change, I think. So what you might notice is that there's a change in that person. So they might be quieter than usual, they're not themselves. And I was talking to someone a couple of days ago that was talking about somebody that at work that had stopped sitting with everyone at lunch and had been late to a couple of meetings, and was really apologetic about that when it was mentioned to them, and people had started commenting on it in the staff room, for example. Have you noticed that he's not, you know, joining in this much? I wonder if he's okay, and in a really compassionate way, but no one had asked him or checked in with him. But there was a conversation going on about it around him, and I think that captures it really nicely. Is that there's a change in some way. So they might start making mistakes, work's not up to standard, arriving late, they might be irritated or short-tempered. It's really, really hard, you know, maintaining that that composure when you're trying to manage mental health difficulties. They can be exhausting. So especially if you're not sleeping, you're not eating, you're not looking after yourself, you're really preoccupied, you're finding it hard to concentrate. It's understandable then that your tolerance is significantly reduced. So yeah, you might notice them being short-tempered with other colleagues, with yourself sometimes, and with customers. They might be indecisive, and you might also have noticed that they've been off a few times with physical health problems. So we know that physical health and mental health are really closely related. When we're having psychological problems, our physical health often deteriorates as well. And you may notice that they're asking for reassurance, or there's a change in sense of humour. But I suppose as well as change, something else that might or that has come up, I suppose, is when you're employing new people or you start working with a new member of staff. It might not necessarily be a change, but you just may notice certain behaviours that are quite different, I suppose, to what you would usually expect. And obviously, this isn't the case for everyone, because everyone's different and will work differently. But what you might notice is that they might be staying later than everybody else, or you know, wanting to double check things before they hand it over, or they may just look tense or anxious or on edge. And so yes, it won't necessarily be a change, but it might just be a sign that somebody is trying to manage some ongoing difficulties that might be worth asking about. And then the next slide says, can you move us over? Just going to talk really briefly about what you can do. So I think most importantly is having that clear and accessible procedures for reporting difficulties. And we often talk about like creating a culture in which people feel able to open up and share. And I think that sometimes can sound a little bit abstract to employers, but what we're actually talking about is, like Heather's just mentioned, is about providing them opportunities. So them one-to-ones, checking in with people, not just asking about workload, but asking, you know, are you okay? Is everything okay? How are things going? Taking time to get to know your staff. We know that investing in your staff means that they are happier and that they work better. And it also allows you to, if you know staff better, then it allows you to kind of pick up on any changes more easily, but also makes you feel more comfortable about approaching them about anything that you might have noticed if you have that relationship already. And also, don't feel too much pressure to do or say something. I think I speak to lots of people that can feel quite anxious about the thought of having these conversations. And often, what we find is that people that have been managing difficulties, it's quite a relief to get it off their chest and to share with you what's been going on. And it can actually massively help if you respond in an understanding, empathic, normalising way. You don't have to necessarily say anything that is going to, you know, make them feel better, but just responding in a human way is the basis of the work I do. It's really important and really powerful. So and if you are going to kind of offer anything, then it's about like saying what can we do to help, what can we do to support you. Can you just go on to the next slides?
Yeah, just before we do, sorry Lucy, my screen wasn't working then. I wasn't just totally like blocking out. But anyway, I'm back on now. But I just think, just on that point you were just saying there, I had a situation with a client couple of weeks ago. And what had happened was, it was a big business, a very number of sites, and the management had changed at a particular location. We had a member of staff that had been with the business for a long time, I want to say sort of plus 10 years. And the central HR team were notified of a problem with this particular member of staff, in that customer complaints had been received about this person, and there were some issues and disciplinary action was being mooted. And the HR manager rang me about it, and she said, it's so strange. She said, you know, we've got this person that's on the face of it got, you know, a perfectly clean disciplinary record, you know, has been a very loyal, good member of staff, and there's, you know, this change of manager has just created these problems. And you know, I said, well, has anybody actually sort of addressed this with him yet, or is it just being talked about? And she said, well, no, we're just talking about whether we take disciplinary action. And I said, well, why doesn't someone just pull him to one side and just have a conversation about these issues as a first sort of port of call? And it turned out this guy, his wife had left him, and he was in a custody battle over his children. And he just, you know, he was just going through hell basically at home, and he was completely, you know, he basically admitted that he was completely ashamed. He didn't want to tell anyone, but actually someone just asking him how he was and what was going on, he felt able to just offload it, and for the relief for him to be able to offload all these worries and problems. And the manager couldn't solve them. He couldn't bring his wife back or his children or whatever. But what could happen, I suppose, in that situation is not a disciplinary process, because it wasn't appropriate. It was more appropriate to support this person and try and help them move on and get the help they needed. So, and again, that just goes back to what you were just saying, in that it's just about actually having conversations with the person. What's going on? Rather than tittle-tattling behind the back, or perhaps sort of the first communication that person gets is an invite to a disciplinary meeting. So sometimes it's just about, and it's easier for us because we're not necessarily in the business, so we've not got the stress or the pressure of having to deal with things, you know, right at the time. But it's just about thinking about what, you know, you can do around just formalising things by a disciplinary process. Just thought it'd be interesting one to share with you. Okay, pass back over to you.
Can you just, is there another slide before that, Stace?
I don't know. No.
Right, okay.
I want me to flick forward and...
Yes, oh yeah, there's so just carrying on from that, that previous slide, it is so asking what you can do and trying to accommodate that to prevent them, I suppose, with the aim of preventing them from going off sick, so supporting them to stay in work whilst they're managing whatever difficulties they've got going on. I know this is the case for everyone, but the majority of people will probably want to stay in work as well, because it provides a routine, it's a structure. It's really important, a part of our mental health, having that kind of sense of achievement that we get from work. So supporting them in being able to kind of maintain that is like really important. If somebody is, you know, does need to take time off and is taking time off, then I also think that one of the important things is maintaining them lines of communication, and that's for you and for them. So I think that people that are off work sick, and this isn't for everyone's situation, but a lot of people will feel guilty about being at home. They'll feel bad about it. It's not very socially acceptable, I suppose. We value productiveness. We value people who are at work, so it is hard for them as well. So I think maintaining them lines of communication, letting them know what's expected, you know, or what you're kind of hoping for. Like, I'll get in touch with you, or our manager will get in touch with you every couple of weeks. We'll just check in to see how you're going, how are you doing, and that can hopefully also make them feel more comfortable about returning to work, because they know that you're still there, that you still kind of care and want to support them in getting back to work. And then for you as well as an employer, I think it's you hold a really difficult role, because I think part of your role is responding to somebody's difficulties with compassion and understanding and that human side, which you will notice and which you will, you know, often feel when you're talking to someone. But also you've got to balance that out with the fact that you're a manager or you're a business owner, and that you've got responsibilities to that as well. So what we often, or what I can see, is that people will jump from feeling really compassionate and understanding and wanting to give them time and wanting to support them, to actually not being able to do that, and also feeling quite irritated about the situation as well, which again is, you know, completely understandable. So you might get other people saying, when are they coming back? What's going on? You know, we can't run a business like this, that kind of, which can kind of like raise your anxieties. But I think that maintaining that communication gives you some sort of sense of containment as well, and security, that you're in touch with them and you kind of have an idea about what's going on. And then the final one is kind of knowing, you know, what, I suppose when you've done enough and what you can do, there's only a certain amount that you can as an employee do for somebody, and you know, and that's okay, and knowing when there's nothing more that you can offer, I think that's important as well. And then if you just go on to the next one. And then in terms of signposting, so it is possible that you know, that people will already been in touch with their GP. You might have got a sick note, and that might be your first kind of awareness of what's going on. But for people that haven't accessed support, then going to their GP is, I suppose, the first line of support. Encouraging them to speak to family and friends if they haven't already done so. Again, people can hold on to a lot of stuff and sometimes can feel ashamed about sharing what's going on. And then there's also what we know as, or what are called IAP services. So their services, increasing access to psychological therapy services, and people can self-refer to those. And they are supposed to act as like a primary care service for mental health. And so they're supposed to offer timely and effective, relatively short-term interventions for common mental health problems. And they are national services, so they should be available everywhere. Waiting times will vary, but they're really well evidence-based, and from my experience they offer a really good service for people. And then you can also, you know, mention about support lines. This is something that sometimes I forget to do in practice, but when I do it, people do say, you know, I did ring that line, like that support line, in the middle of the night when I was feeling really low and alone, and it was helpful. And so that's just one option. And then another thing, just as well to say, if they're ever feeling suicidal, then, you know, they can call 999, they can go to A&E. You know, that's an emergency, and they should access an emergency help. And in terms of your role there, so when you are meeting with someone, you might enter that meeting with the understanding that what you talk about is confidential and it won't go, you know, beyond the room. But if you are concerned about anybody's welfare, then, you know, it's okay for you to break that confidentiality. You can let that person know, if you feel safe to do that you're going to do that because you're worried about them. So, and you can ring, you know, I've had to ring the police before, and or you can ring a family member. You know, that's okay. And then if you could just go back, Stace, to the my role, and then just in terms of my role in this. So part of that could be to offer occupational health assessments. So these are, I suppose, impartial, independent assessments that aim to provide an understanding of somebody's current mental health difficulties, and also often it's to inform the whether they will feel whether they're going to be able to return to work and when that is likely to be. So that the aim of these is to provide really kind of straightforward practical advice to allow you as employers to make decisions usually about someone's employment. Sometimes I can make recommendations which can support people in getting back into the workplace as well as part of that.
Because I think sometimes, sorry to interject, Lucy, but I think sometimes what can happen is that the first you hear of an issue is, you know, you receive a fit note and it's got like 2 words on it and they signed off for a month and you think, what the hell, you know, like what's happened here, and nobody has any clue and you don't know enough, and it's like, you know, and I think when that absence does sort of become longer term, then that's when they would need to come to someone like yourself, Dr. Lucy, to say, well, look, what is actually happening, and is it work related, is it not, is there anything we can do, are they ever going to be able to come back to work, you know, if not, you know, what's the process look like? And also I think as well, going back to that point that Heather said, if there's sort of internal processes happening, so if you've got a grievance procedure or a disciplinary procedure happening, then sometimes you need some advice and some input as to how to conduct that process without exacerbating any condition, because sometimes issues need to be addressed, like you've no choice, you've got to address behaviours, but you want to do it in a way that's not necessarily going to be detrimental to that person's condition or health. And it's very hard that when you're in, you know, you've got real no understanding behind someone's, you know, condition, and you've got a fit note that tells you very little. And, you know, I've seen it time and time again where you go to the GP and the GP can't give you any information. And I think largely, Dr. Lucy, that's because GPs unfortunately aren't qualified, are they, in this area? You know, they're general practitioners, aren't they? They're not actually experts in mental health.
Yeah, they're often very busy and don't have time, and lots of reasons. So, and then another part of my role is offering training to senior managers, and this largely covers, I suppose, what we've talked about today. So, and I think with the aim of supporting people in feeling more confident in having discussions around mental health with employees. People can find conversations like this uncomfortable and anxiety provoking because it can feel a little bit like an unknown. So just the opportunity to have that that access, I suppose, to information, which allows us to develop our understanding and then our confidence in having these discussions and knowing what to do as well, if somebody does come to them with a difficulty. And then the final part is for employers that want to offer some more, you know, want to offer one-to-one support to their staff. I can this often splits into two different parts, I suppose. Sometimes I might do an assessment, which is maybe 1 to 2 sessions, which is like an assessment and then an initial understanding or formulation of someone's difficulties, with the aim of signposting them on to other services that they might be able to access. And as well, sometimes just that process can be quite helpful for someone. Just an understanding of what might be going on can be really useful. And then as an alternative, we can offer longer term therapy, I suppose, which aims at providing an intervention to someone, like an evidence-based intervention, which is usually between maybe like 6 or 12 sessions, where you aim on supporting them with their difficulties.
Brilliant, thank you. Right, Heather, where are we up to? We're doing the case studies next.
We are?
Yep, cool. Right, so we just thought it'd be helpful, everyone, just to try and put some of what we're discussing into some context, just in terms of some examples. So the first case study we're going to just chat through together is about Jake. So Jake's an operative in a warehouse. He's 12 years service with his employer. He's autistic, and his colleagues are aware of this and understand he struggles mainly with his social interaction. Jake is very committed to his daily routine and struggles if his routine changes. The business is in the process of introducing a new system in the warehouse, and Jake is finding it difficult to cope with changes to his role. One day he reacts badly to instruction from his manager and starts to shout and swear and offend some of his colleagues. Over the course of the next week, Jake is disruptive and refuses to follow instruction, instead just reverting back to his old way of working. The business want to consider disciplining him for his outburst and failure to follow management instruction, and they need advice on how to move forward. So what would we say, if I come to you, Heather, first, in terms of their desire, I suppose, to discipline, what would we be saying about that?
So first of all, that we can understand why that might be on their radar. You know, we've got here that he's shouted and sworn and he's offended people and being disruptive. So we can see that there is potentially some misconduct there. But as with everything, and with most disciplinary processes, the starting point should be to investigate that. And in a scenario like this, where it seems like we are aware that he has autism and that might have played a part, knowing that he's gone through some recent changes, again, not being medical experts, but noticing that there's been a change, perhaps, you know, he's a long-serving employee here. We don't know if he's got a clean disciplinary record, but let's assume he has, then there's something out of character here, really, and we know he's got a mental health condition. So the first thing for me would be saying, let's talk to him informally as part of our fact-finding exercise to just try and hear from his side how he feels he's been feeling and behaving recently, and just trying to establish, before we go into formulating allegations or being very accusatory, being very, very neutral and just trying to do some of that fact finding before we're getting to the point of inviting someone to a disciplinary.
Yeah.
And, you know, the reality is we've got failing to follow reasonable management instruction, we've potentially got other behaviours there, but it seems to me that there's going to be mitigation here. So what sometimes I think employers are very much like, well, it's in our list of gross misconduct offences, perhaps to use foul and offensive language or to offend colleagues in this way, or failure to follow reasonable management instruction. And that's fine. And it might be appropriate to warn that it's potential gross misconduct or there's potential there for quite serious consequences. But to me, in a case like this, it seems like there's going to be significant mitigation.
Yeah.
And even if in other cases the sanction might be dismissal, or it might be a final written warning, it might be that we do need to think about adjusting our approach, or giving Jake some adjustment and some slack, really, for the fact that that there's been this prompt.
Yeah, and I think probably equally as important really is, I suppose, addressing these behaviours with him, but also how do you move forward, because they quite clearly need, as a business, to make these changes. So how do they move forward with him to try and sort of get him on the right track?
Well, that's it. I think people generally can struggle with change, and change can happen in a workplace and can be necessary. Part of a disciplinary outcome sometimes is saying what we expect the employee to do moving forward. But I think in a case like this, you're absolutely right. How are we going to avoid future outbursts? We've got a part to play in that as the employer. So what can we learn from this in terms of how we might have maybe perhaps managed it better, in terms of how he's best dealt with change? Because we may feel that relatively minor changes, this new system in the warehouse, the majority of staff may be quite comfortable getting a day's notice of that, or 3 days notice of that, and it being just a simple email to all staff. Well, we're going to have to bear in mind that there might be individuals within the workforce that we need a more tailored approach with.
And I think that probably does link into the whole sort of, duty on employers to make reasonable adjustments for employees that would be, technically classed as disabled. And that's probably, Dr. Lucy, where you might be able to help in terms of, well, an employer does have this legal duty to think about, right, okay, what can we do? What changes can we make in the workplace to help this person? But actually, as you might not have a clue what they look like, it might not be obvious. And generally with mental health, it isn't obvious, is it, as to what can happen? So I suppose that's where we would come to you and say, well, what can we do?
Yeah. And I suppose what I'm going to suggest really overlaps with Heather, but I think the initial thing that comes into my mind is has Jake been involved in any of these changes? Was he aware of the changes? Just going back to what I said about taking a preventative approach, so thinking about supporting your employees, if you're kind of aware that it might be a struggle. And also he'll be really aware of, likely to be much more aware of his own difficulties and knowing what, and will probably be aware of what helps and how he usually manages change. And so involving him in them discussions, asking him what can we do, what helps. So it's really important.
Yeah. Good. Okay, so if we move on to the next one. We're talking here about Molly. Molly's a 33-year-old single mum. She's worked as a receptionist at a hotel for 10 years. She's recently lost her mother to cancer. And over the last 12 months, Molly has been absent from work more than she has been in. The doctor's fit notes cite a variety of low mood and anxiety and insomnia. Her manager knows she has suffered with postnatal depression in the past, and Molly has talked openly about a general battle with depression throughout most of her life. When in work, Molly is very good at her job. However, her absences are very disruptive. They don't want to lose Molly, but things can't continue as they are. So that is a very difficult one, isn't it? Because you can tell just from the context there that there's obviously a lot of sympathy with her situation. But then as a business, you can't continue, can you, with someone who isn't actually able to do the job.
Yeah, so I think the first thing for me, Stacey, on this one is the starting point. Let's see what this particular company, this hotel, what is their attendance policy? Do they make clear what their expectations are? Do they have some triggers? And sometimes what I see, Stacey, I think we've both seen in practice, is that where there is this real sympathy and they know there's a genuine problem, and that they want, they're a good egg when they're in work, so we want to kind of be nice to them. We don't think that they're putting it on. Then sometimes businesses do nothing at all to manage that absence, because they just cut them a lot of slack until they get to a point where they can't tolerate it anymore. And actually, I find that worse, because most attendance management policies or sickness absence policies, the starting point is having those welfare discussions, is actually talking to the employee, potentially looking at whether we need to get somebody like Dr. Lucy to provide a report, understanding their condition, understanding how it may impact attendance, and what preventative measures we might be able to take to try and help keep them in work. And if we've missed all of that, then we've probably missed some opportunities there. And I think in terms of trigger points, again, if you say in your policy that if you have 3 or more occasions within this sort of period, we'll have this sort of meeting, don't just not have it. If you think that it's, there's real genuine and we want to be very sympathetic and supportive and give that person some further opportunity, it's likely to be absolutely the right thing to do to potentially adjust those triggers, to put a little bit of slack in that process. Because it's not just, I've been off with a cold, a sore toe, a bad back, a Monday morning after a Sunday night of the football or whatever it is. We can treat it slightly differently, but it shouldn't be like an all or nothing approach. So I think ultimately trying to find out if there's anything we can do to help support the attendance, but following the company's absence management process, perhaps with some adjustment as to those triggers, so not quite as quickly moving to the next stage of the process, for example, but ultimately we're then getting the opportunity to explain to Molly the impact of her absence on the business and on the team.
I think we get it all the time, don't we, Heather, where they think the business thinks they're being kind by just sort of letting it happen until it gets right. That's it, we've had enough, it's been 12 months, we're not doing it anymore. And then from the employee's perspective, it's a bit of a shock to say, well, it's been fine up until now and you've been supportive up until now, and then all of a sudden it's not okay, and that's it. So the point there is that you're better off keeping in touch, regularly monitoring, having the same sort of, like you said, management meetings that you would have, but with the adjustments. And I think perhaps then for you, Dr. Lucy, in terms of if they do want to support and they do want to keep her in the business, and they were thinking, well, how can we, is there anything we can do in terms of supporting her, then that's again when they could come to you and say, well, do an assessment, is there some therapy that can be offered to try and help her deal with whatever's going on in her life that she's having problems with.
Yeah, and just finding out what kind of support she's accessing outside of work, and checking that she's doing that, because there is some, it's not brilliant, the access to services, but there is there is hopefully something that she can access. Yeah, and I think again, what I would say really overlaps with Heather in that, you know, making sure that you're involving them, having them open discussions. If you're having questions, ask. You know, if you can't ask the person, share the dilemma with them. You know, they will hopefully want to kind of support, you know, work together. Yeah. And it sounds like this person has that relationship with her. So, and obviously it will differ for everyone, but
yeah. So communication is key. I think is a key message from what we've just said, isn't it? Communicating. Good.
Stacey, just before we move on from the case studies, I've seen there's a question in the Q&A box. Sorry, it was going back to case study 1, and we might have sort of answered it. But the question is, and it's sort of, I guess, between both me and Dr. Lucy here, are you considering autism to be a mental health issue? My understanding is that neurodiversity conditions, such as autism spectrum disorders, are considered disabilities under what was the Disability Discrimination Act, obviously now the Equality Act. So I'll start with sort of my perspective, which I guess is the second part of that question, because to me, the sort of label or the diagnosis or the condition is not that important. To me, it's, is there a mental health, and unfortunately the Equality Act term is impairment, but is that having a substantial adverse impact on normal day-to-day activities, and is it likely to be a long-term condition? So for me, I understand that autism, you know, there's a spectrum, and Dr. Lucy will be able to comment perhaps slightly better on that. It might be that some people who might have that diagnosis don't meet that definition, but certainly there will, in my experience, be a significant number that are likely to be classed as disabled. And again, if in doubt about this sort of thing, this is where occupational health or people like Dr. Lucy's reports are really invaluable, because what you can do is, whilst that is a legal question whether someone's disabled and it'd ultimately be for an employment judge to decide, we can ask the medical professionals, we can break down that legal test into questions and understand if they're likely to be met, and that definition is likely to be met. I don't know if Dr. Lucy, you've got anything to add to that at all.
Yeah, I guess it is one, when I was saying earlier about, you know, mental health being complex and it not being, you know, there's some questions that, you know, are always left kind of not with a straightforward answer. But in terms of the diagnosis of autism, it is, I suppose, viewed as a developmental disorder, and not necessarily in the same category as another mental health disorder. This is from like I suppose like a mental health perspective. But it does come under, so it is in the DSM, so it is in the diagnostic manual for alongside the other diagnoses. So it is a little bit confusing. On in some parts it's different, and it'll be treated differently, but in other ways it isn't, if that makes sense.
Yeah. So and I think ultimately as well, Dr. Lucy, I suppose it's you know, there's this seriousness of their condition, you know, might then lead to other mental health problems. Course, yes. So that in itself might then breed other issues, other problems like the OCD or whatever. So it is such a complex area, isn't it? And like Heather said, it'd be a case of breaking that legal test down into certain brackets, and then coming to a conclusion on it to decide, okay, what's the legal position? Because it being totally blunt, if someone is classed as disabled under the Equality Act, then from an employment law perspective, we need to be super careful. If they're not, if they're not, then you've got a bit more flexibility in terms of what you need to do. And that's not to say that you don't necessarily want to be supportive, but it just means that you're not legally obliged to be. So, you know, it is quite an important question. So thank you to James, you know, for asking that. Thank you. Okay, so let's have a look, Heather, at, I suppose that links in quite nicely, doesn't it, with your next slide?
Yes, it does. And I'm going to try and pick up on another sort of question as I talk about this as well. So ultimately, exactly what Stacey's just said, one of the key areas from a legal perspective that we're thinking about when we're dealing with employees with mental health conditions is they may well be protected under the Equality Act and classed as a disabled person. As I've mentioned, there is that legal test there. It's physical or mental impairment classed exactly the same. So is there a mental impairment? Does it have a substantial adverse impact on normal day-to-day activities? And is it likely to be long-term or reoccurring over a long-term period? And that long-term, we're talking about 12 months. And unfortunately, again, in my limited experience, mental health issues can quite often be long-term. There isn't always a quick fix. So, and for the purposes of considering if it's having a substantial adverse impact, the benefits of any medication are disregarded. So if we are saying that, look, someone appears to be operating functionally and within that normal range, but if they stop taking their medication, they would really struggle, then you do, when you're assessing whether someone's disabled, you ignore all of the potential aids and support that they might be receiving. And then there's various types of discrimination that we want to make sure, obviously, that we're avoiding as best as possible. So direct is the most obvious type, and hopefully we don't have too many examples of that. And that's where we're treating someone less favourably directly because they are disabled, because they have that mental health condition. So if we're saying you aren't eligible for a promotion because you've got bipolar disorder and therefore, we don't want to offer it to you, then that will be direct discrimination. Indirect discrimination is where you have some sort of practice or provision or criteria which puts disabled people at a particular disadvantage. That can quite often, sometimes we do have to have practices and policies like that, but they will only be unlawful if they can't be objectively justified. So, for example, even maybe having a policy that you have to be in the office at 9 a.m. in the morning may put people with depression who may struggle more in the mornings at a particular disadvantage, for example. They might try and allege that, but we would say, well, due to operational reasons, due to the fact we open to customers at that time, etc., it's justifiable for us to have that policy where that's the core working hours of the business, for example. Disability discrimination arising from something in connection with the disability is a very broad category of and can be, if you like, the easiest type of claim for a disabled person to bring, because it's very wide ranging in its scope. So the classic example of this would be sickness absence. So you're not treating me unfavourably because I'm disabled, you're treating me unfavourably because of my sickness absence, and that arises from my disability. Now, again, that can be justified. So again, we would want to show that, well, we've got an attendance policy, we've actually hopefully applied that fairly and objectively, having regard to the disruptive impact on the business, and we've balanced out that prejudice to the employee as compared to us. Harassment, again, you might think, well, you think about sexual harassment or things like that, but harassment within the Equality Act just means unwanted conduct that is connected to a protected characteristic. So if somebody is treated in such a way that is connected to their disability and has the purpose or effect of creating an intimidating or hostile working environment or degrades them, then that will be harassment. So sometimes, and I completely appreciate there's a bit of banter in the office or people like to make light of situations, but you've got to be extremely careful, because if you are making a joke of someone's mental health condition or something like that, then the reality is that could well be unlawful harassment. And then failure to make reasonable adjustments, obviously a really key one, and it's a specific type, again, of discrimination saved for protecting disabled people. So if we know or ought to have known that somebody was disabled, then we should be making reasonable adjustments to alleviate any substantial disadvantage they're placed at as a result of their disability. Now, it is only those that are reasonable, and again, we might need support from someone like Dr. Lucy or what have you to give us some ideas as to what that might be for that particular person with that particular condition. And then obviously in terms of if we are dismissing somebody who is disabled, that might be discriminatory or it might not be, but we've got ordinary unfair dismissal to think about. So if we've got 2 years service or more and we're dismissing someone for attendance, for example, we have to show that we have got a potentially fair reason, which we should have in terms of capability, and that we followed a fair procedure and that reason was sufficient for dismissal. The last one is constructive dismissal. So this is where someone feels forced to resign as a result of the employer's conduct. So usually here we're talking about trust and confidence. So we've talked a little bit about sort of confidentiality and when it might be necessary or appropriate to breach that. But generally speaking, if we're having these welfare chats, if we want to have this open dialogue, if we want people to feel supported in the workplace, then we've got to make sure that we're treating them with respect, keeping their personal sensitive data confidential where appropriate, and ultimately providing a supportive environment. If instead we are creating an untenable environment and working relationships are very, very strained, and we don't react well to somebody with mental health conditions, then they may well resign. And again, if they've got 2 years service, they could potentially bring a claim for constructive dismissal.
Yeah, I think one of the key sort of points as well, Heather, is, you know, obviously when we obviously advise on these matters, literally as part of our day job, really. And sometimes it can be frustrating when you've got somebody who, you know, they've been signed off work for a long period of time with a mental health condition, and the business is saying, well, we just can't hang on forever, and we you know, there's nothing we can do, and you know, they're having all these problems, and you know, we need to bring it to an end. And I think it's really important to highlight that it would be unsafe to terminate someone's employment or start to implement any sort of disciplinary processes without getting medical input. Because I think what an employment judge would always say is, you know, they're not experts, they're not medical experts. Lawyers aren't medical experts. Managers generally aren't medical experts. So that's why you need to go and get occupational health support. And sometimes it can be frustrating because you think, well, you know, they've been off for 6 months now, I've got to spend X amount of pounds getting an occupational health support. But for what? Because we can't do anything. But the point being is, a judge would say, you don't know you can't do anything. You don't know that there's no hope. You don't know that there's no adjustments that can be made. And actually, if you've got somebody who's been sat there not accessing support because they don't know what to do, they don't know where to go, people don't necessarily have, you know, people around them at home that are going to help them, then actually with the right support from their employer, they could make progress. And that's the key legal position, is that you don't know. So that's why we've got to get the medical input. And even if it just comes back to say, well, yeah, unfortunately, it's unlikely to remedy, you know, to be able to be remedied within the next X amount of months. Right, okay, fair enough, but at least you've had that input.
Definitely, and the point there, isn't it, Stacey, is that I think sometimes the employer really turns to the employee and says, well, they've not told me that they need this, that and the other. And unfortunately, we can't do that legally. The burden is on the employer. So you might either have employees that, like you say, just don't know themselves or are in denial, or you know, they might think of one thing, but it's not reasonable, so we discount it and we say, oh, we've ticked the box of reasonable adjustments. The reality is, as you say, the burden is with us, and we need that medical input to help us with what adjustments there might be. And we can then decide if they're reasonable or not. You know, that's fine.
But it's just about risk, isn't it? Ultimately, it's putting all the welfare thing to one side, which obviously we've got a duty of care, don't get me wrong, but in terms of actual business risk, if you terminate someone's employment or take action that could be deemed unreasonable, then you're putting the business at risk. And the whole point is that you've got to go down the right routes to make sure that, you know, you are protecting the business. And unfortunately, and I see it all the time, you know, let's speak to the GP, let's go back, well, what was the GP saying? When did you last see a GP? And what did the GP say? And And I keep, you know, repeating the fact that unfortunately the GPs are just not in a position to, you know, to diagnose mental health conditions. They're not in a position really to treat. All they can do in the first instance is refer them on to someone within the health service that can treat them and sign the fit notes. You know, so you're not going to get anywhere, unfortunately, by just keep asking the GP or getting the employee to ask the GP. It's unfortunately not that simple.
And it's not timely, is it? We're in our experience, and like I say, the quality of the reports aren't brilliant. The question I've had, Stacey, is about where it might not be the employee with the issue, it might be their spouse or partner, and I guess that could be impacting on them. So I'll touch on that. I mean, I think the reality is that there is only so much we can do, and they're not they're not the person that we're going to be communicating with, but clearly it might be then even more so. Dr. Luce was saying about how work, it can be very important for people who are struggling. We can provide our employee with that support. In terms of, from a legal perspective, you shouldn't discriminate someone due to their association with a disabled person. So there is associative discrimination, but that only goes as far as direct discrimination, really. So if you were saying, well, your wife or your husband, they're having such an impact now, I'm going to sack you for that, then that could be discriminatory. But the reality is we don't have to make reasonable adjustments for our employee who's a well employee and not disabled because of their spouse or partner who's got a disability. So it does come up, we have carers, we have parents who might have disabled children and things like that. Yes, of course, we might want to be supportive of our employee, but it doesn't extend to obviously a spouse or partner. So yes, of course, if they might have private medical insurance as part of their employment that covers their family, their spouse, or there might be employee benefits that extend to spouse and family, but it's not really for the employer to engage with family members.
Yeah.
Okay. Should I go on to, I've got a couple of examples. I'll make sure, I'm conscious at 20 past now, I've got a couple of examples of some relatively recent cases that I know people find interest as well as our case studies, but I'll make sure I just leave a couple of minutes at the end in case there's any more questions coming through. So this first one is quite a recent case from sort of winter 2020. We've got a disabled fire station manager who was dismissed for what the employer called unacceptable attendance, and he succeeded in a disability discrimination claim, and there were a couple of elements to his claim, but the interesting one here is that he brought a claim, that category of discrimination arising from disability and also a failure to make reasonable adjustments. The reality is he'd not obviously worked there very long. 2nd of January 2019, so dismissal in October 19. But the key sort of issue here is the way the London Fire Brigade dealt with it was to subject him to a disciplinary procedure and sort of really dealt with it as like an offence. Now, it's quite interesting. Some people, companies, policies, it's quite unusual to use the disciplinary one to deal with absences, but I do know that for sort of short-term persistent absence, it can be, it is possible to sort of see it as like a conduct issue rather than a capability one. But clearly here, he's cited mental health issues. He did meet the definition of being a disabled person. So actually thinking about it and trying to use sort of the right process, the right labels, and dealing with it using the right sort of policy being quite important there. So that was a little bit of a word of warning in terms of just sort of checking your policy and making sure we're not necessarily treating it as you've done something wrong, like misconduct, by having a mental health issue. So they just obviously didn't deal with it the right way in that scenario. The outcome of dismissal might well have been fine, but they didn't sort of follow the right procedure, it seems to me.
Okay.
And then flicking on to the next one, this is the case of an employee with long-standing history of mental health problems. This one's it was really quite complex. Alcohol dependency and depression. So just to make people aware, alcoholism is expressly excluded from the Equality Act as a disability in its own right, but clearly can very much be part and parcel or linked to mental health conditions which are disabilities, such as depression, and I think this lady also had stress and anxiety. There's a couple of similarities with our case study about Jake and the difficulties with change, and that was very much the case here. She was an admin officer, and she'd been told that she needed to move teams. She was very, very clear that that would cause her to be very, very unsettled. They were very much aware of her mental health issues, and she apologised for, I know this is a small deal to some people, but for her it wasn't. And ultimately she did have periods of sickness absence. The employer wasn't very sympathetic. She did ultimately move. So she obviously gets settled a bit on the new floor and in the new team. And then in 2015, whilst she was off sick, she was again told with immediate effect she was moving to a new team, new manager, and moving back to the different floor. Again, she sort of resisted and told the employer what difficulties she'd have there. So they did sort of talk about phased return, and when we talk about some of the adjustments that might support people, particularly coming back from absence, phased return is one of them. But again, it was, could she temporarily, while she's sort of trying to come back from work after a period of ill health, work at her old desk for a period of 2 weeks. And ultimately the employer, I think they'd really lost patience with this employee, and they just said, no, it's not reasonable. As soon as you're back, you need to move to this new desk. And ultimately, the tribunal here held that the employer had failed to make reasonable adjustments by not allowing to work at her old workstation for 2 weeks. And also, when they ultimately dismissed her for a continuing absence, it was that discrimination arising from disability. They didn't feel that dismissal in those circumstances was proportionate and justifiable, as they sort of contributed, I guess, really to the dismissal, and perhaps missed the opportunity to take other action before they got to that dismissal point. So the stark reality in this case is that this individual was awarded over £75,000 in compensation for the discrimination that she had suffered during her employment, and with regard to her dismissal, obviously including loss of earnings. So it was a difficult case when you read it, but there was clearly some learning points in there, and I do think that bit of patience, or people just saying, well, no, she can't have that. No, is it reasonable? Can we do it? What's the impact on us of someone working at a different desk for 2 weeks? That's the sort of thing that I think we've got to ask ourselves there and just reflect on.
It's interesting as well, Heather, isn't it, that we unfortunately see some of the highest awards for compensation in disability discrimination arenas. So generally speaking, compensation in employment tribunals is capped. It's relatively low, it's not extreme, but at a sort of higher end is disability discrimination, and that's when you see the sometimes six-figure sums that sometimes going into millions, and that's why we do have to be really careful, and that's why sometimes when we are advising on processes, we are quite prescriptive, and we do insist on certain things taking place, and it's all, like I said, around this like risk management and just making sure that you don't end up in a situation where you're kicking yourself thinking, well, if we'd just done that, or we'd just sort of had that one meeting, or we'd just got the occupational health, you wouldn't necessarily be in a tribunal scenario, because it is the messier of the claims that we deal with, unfortunately.
Definitely, because we're talking with not only potentially loss of earnings that won't be capped, and injury to feelings, which is relevant in all discrimination claims, but potentially injury to health if we've exacerbated a condition, you potentially aggravated damages, psychiatric injury type awards, and obviously we've got there might be a separate personal injury claim as well, potentially. So there is a lot of extra potential risk. And if people, I've dealt with cases where they've had career-long losses, you know, they're not going to work again as a result of their discrimination. So that's where it's...
And ultimately as well, I suppose from a PR perspective, it's not great, is it, for a business that is in that situation where they're seen, you know, to be treating people unfairly, especially around obviously the mental health and disability. It's not going to do you any favours from an employer's perspective. Yeah. So,
and obviously all the judgments are published now; they're all publicly available. Yeah. So the next one, this was again a first instance decision about an employee who was, and this is come up quite a few times, Stacey, recently in our practice, where they're giving some information at the start of employment in a health questionnaire, but what are we doing with that information? And is it being actioned? Because when we're talking about an employer having knowledge of a disability, if we've got some health information there, but that's not acted upon, or managers aren't actually aware of that, or we just ignore it, put it just in a drawer. Yep, they seem to be, there's nothing major, then that can be a problem. So in this case, she referred to taking some medication. So it asked a question about if you were taking any medication. She referenced the name of the drug and just said to control anxiety. She didn't otherwise reference on the form that she had a mental health condition, or that there was anything else sort of impacting her fitness or ability to work. But she was also receiving CBT treatment, and she had suffered from anxiety for a long time. She was obviously in quite a senior role, and as part of her role was required to attend meetings and site visits, and she informed her employer that she struggled with anxiety in those scenarios. The employer switched her to a different role, and during the course of various meetings informed her that she would not progress further with her career until she sort of resolved her issues around that. And ultimately, she brought a claim in terms of that sort of cap on promotion, and it was found to be unfavourable treatment because of something arising from her disability. So it wouldn't necessarily be reasonable to promote someone if their disability inhibits their ability to carry out a role. However, again, it's this important point about evidence. So they'd made their own assumptions that she wouldn't be able to do that, but they'd not looked at getting any advice, even from the employer's GP or an occupational health report, as to how actually, potentially, I guess, if they'd have made adjustments. Because I think in this scenario, it was the other personnel, I guess the way they were setting up these meetings that was potentially aggravating her anxiety. As who else was there sort of watching her while she was attending these meetings or site visits. So the reality was that, again, a combination of reasonable adjustments and then arising from, so you do quite often get more than one of these types of discrimination at once, and again awarded over £50,000. So again, it's not that the employer couldn't have got to the same decision, but they'd just not got that medical input. And then the last one, I'm really conscious of time, I'll just touch on this briefly, and I'm ending on a positive note. It kind of links in with that point about what do we know and what ought we have known. So in this scenario, the employee was disabled, they had depression, schizophrenia, but they didn't disclose anything to their employer. We did know that she'd had 30 days sick leave in a previous job, and she did have quite high levels of sickness absence with this employer, but she didn't give the real reason when she was off. So we do sometimes see that, you know, people might just say sick or had a stomach bug, and that might not be the real reason. The reality was then, when this person was dismissed for her absences and poor timekeeping, when she brought a claim of disability discrimination, it failed because the Employment Appeals Tribunal accepted that the employer wasn't aware of the disability and shouldn't ought to have known, because the reality is, even making reasonable inquiries, they weren't going to get the sort of truth or the real reason for the absences.
Interesting. Okay, so let's just have a look and just see if there are any outstanding questions.
I don't think there is, Stacey.
I don't think there is. I think we've answered the couple, haven't they? We've come
Yes.
in. Okay, that's great. Well, that brings us to the end of the session. So thank you everyone for joining us. Thank you to Dr. Lucy for giving your time up today to attend and pass on your wisdom, which has been very useful. And hopefully we'll see everyone soon. We'll leave it there. Thank you.
Thank you.